Tonight, we're going into a place of darkness, but also of light. There's a light at the end of the tunnel. So preserving limb and surviving limb loss, resuming an active and productive life. Dr. Douglas Smith is a professor of orthopedic surgery out of Harborview Medical Center. He's also on staff at the University of Washington Medical Center and the Veterans Administration Puget Sound Healthcare System in Seattle. His many functions include serving on the research committee of the Foot Care Council of the American Diabetes Association and is a board member of the Orthopedic Rehab Association. He's a medical director of the Amputee Coalition of America and director of the Prosthetic Research Study. And Dr. Smith serves as a consultant to the United States military out of Walter Reed Army Amputee Care Program. He's editor of the Atlas of Limb Prosthetics and Amputation Surgery in its 3rd edition and has presented at numerous medical meetings. His accomplishments include developing footwear to prevent diabetic foot ulcerations, which are a direct precursor to a diabetic patient losing their limb, as well as directing a prosthetic research study dedicated to advancing the function of the amputee and preserving the limb at risk. He graduated with a bachelor's degree from the University of Notre Dame in Indiana. Smith also received his medical degree at the University of Chicago, Pritzker School of Medicine. He completed his residency at Loyola University Medical Center in Maywood, Illinois, and a fellowship in foot, ankle, and amputation surgery with Dr. Sig Hansen at Harborview Medical Center and Ernest M. Burgess. Before I have Dr. Smith come up, we have a video to show you. And the video was shown on Evening Magazine, and it concerns a young gentleman who was a victim of a motorboat accident this past summer. So I'm going to close this up, and if we could get the video started, that would be wonderful.
Welcome back, everyone, to Kirkland. You probably saw the story on the news last August. 16-year-old boy run over by a boat that his sister was driving. And that was it. The nature of news is they do the story for a minute 30, and maybe they do a follow-up the following day, but they must move on to the next story. Nothing against news, that's just how news works. Evening Magazine for 20 years tells the story what happens after the news cameras leave. The story of Chandler Balkman and his recovery. Now, that's where this story begins. Here's Kim Griffiths.
It was a perfect summer evening on Lake Sammamish. A dad and son raced to that buoy out there, as they often did, neither knowing their lives were about to drastically change.
I saw the boat after it went past me and realized that it was right in the area where Chandler was.
Chandler Balkman's sister, Jessica, was driving the family boat and didn't see Chandler swimming.
Chandler came back up and he said, "Dad, I've been hit and I'm not going to be able to stay afloat. I need help."
For Steve and Jeff Balkman, the details 3 months later are as clear as the August evening when it all happened.
I grabbed my brother and picked him up into the canoe, and I immediately could tell that there's a lot of blood and that his leg had been severed.
16-year-old Chandler, the athlete, Eagle Scout, skier since the time he could walk, was dying.
I actually assumed that my brother was dead at that point.
They carried him into the house and onto the basement floor.
This nice beige tile floor was completely red after a few minutes. Blood was just everywhere.
Chandler thought he was dying too.
He told me to tell his mother that he loved her and to tell his sister that it was not her fault and that everything would be okay.
Chandler was rushed to Harborview in a condition most people do not survive.
About 2/3 or 3/4 of his total blood volume probably had been lost.
He made it through the night, but he was very sick and in a coma for 2 weeks. His family knew long before he did his right leg had to be amputated at the hip.
At that point, there was just no way that this was a leg that could be saved.
Waking up without a leg. How would this active, athletic teenager respond to losing his ability to hike, to play sports, to run?
I decided, said I can either be grieving and mad for the rest of my life, or I can be optimistic from this point on. And that day, kind of said to myself, all right, let's go forward.
Don't let that ankle roll.
You wouldn't guess that a 16-year-old kid that just lost his leg would be so cheerful. And I think Chandler decided from the very beginning that, this happened, and let's make the best of it.
Remember how we talked about coming onto your knee?
And make the best of it, he did. Instead of varsity tennis, his goals became simpler,
There you go.
like learning to stand.
You almost had it. Just a little stumble there.
And so began the toughest physical and emotional challenge of his life.
Oh, sorry. That's all right. It's all right.
Okay?
Yep, I'm fine.
Sure?
I'm sure.
Sorry.
Don't worry about it.
This was kind of the ultimate challenge. Could we be positive about this? And honestly, Chandler led the way. I wanted to be sad some days, and I couldn't do that if he was willing to be positive about it. So I had to kind of just, okay, I can do this. One more day, Chandler can do it, I can do it.
Up you go.
In addition to amputating his leg, the propeller also sliced into Chandler's other foot and broke bones and severed tendons in his hand.
Yeah, I'm trying to break up the scar tissue.
It required at times painful therapy, some 20 surgeries, and the one thing Chandler didn't have, patience. Being stuck in the hospital
Not that flexible.
week after week
I'll probably get calluses on my hands, which is good.
for 10 weeks
Oh, looking a lot stronger there.
Really?
Yeah.
made being homesick a symptom that needed fixing.
I've been here too long.
That's why he was granted a get-out-of-the-hospital free card for a few hours.
I'm so happy. I'm so happy to be here. It's not nice of a day, but I don't even care. I am so happy.
He hasn't been home since the night of the accident.
Yeah.
The visit is good for his spirits, but the main purpose of this field trip
Hey, Grandma.
is to see how Chandler does getting around the house.
Hey, but I can do it. I can do it.
Good. Well, at least there's one bathroom you can get into.
His bedroom is on the top level. His parents suggested he switch rooms with his younger sister on the main floor. No way.
Chandler.
One at a time, don't do two.
Chandler is so thrilled to be home, back in his own room,
Yeah, check it out, man. I got no leg now.
appreciating every detail
It's good to see my clothes.
and getting some family time.
Wow, I was so weak. Oh my gosh.
But you did it, Chandler's not too bad.
The visit is wonderful, but short.
Oh, it's really hard to go back.
He has to go back to Harborview. He has more healing to do, physically and psychologically.
I got hit by a boat, and my leg was cut. It was severed pretty high.
An amputee support group meets every week. Some members lost limbs recently, some years ago. They share about life beyond the hospital and show Chandler he's not alone.
It took a long time to go up the stairs for me because I had to learn how to balance on my knees.
Chandler has to meet certain goals to earn his way home, and one by one, he checks them off his list.
Yes.
Awesome. Good job.
Yes. I've never.
You were having trouble with that
I got
before?
a lot stronger this week.
Awesome.
Mom has to work too to learn to care for his still deep wound as going home day finally arrives.
Have fun going home. There will be some scary stuff, and just to let you know, there will still be a little high and low in your spirits. You'll have a few times down in the dumps, but you got good people around you. Take care. Big thumbs up.
On discharge day, a final meeting with his team of doctors and therapists, make sure Chandler's ready for the real world.
Here we are today. You ready to go home?
No, I think we should stay another couple days. I'm ready.
Good job.
More than ready.
Congratulations.
Thank you.
Just a few final orders of business.
Yep. 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 Yep.
All traces of Chandler will be gone from room 457.
And the Balkmans are ready to roll.
Oh, yes. Exiting this hospital. I'm so happy. Yes.
They have the toughest 2.5 months of their lives behind them.
Go home.
And a lifetime of challenges ahead.
So long, Harborview.
A stay in the hospital and then months of therapy, and 3 months later you can see that Chandler is doing well, recovering nicely. But what about his sister Jessica, who was the one that was driving the boat? Now, she was not physically hurt, but the mental anguish that she suffered, well, that's another story. The family says Jessica still has hard days, but she's doing well. Chandler has completely forgiven her, and everyone knows it was just an accident. And the family convinced Jessica to stick with her plans to study abroad this semester, to go on with her life just as Chandler rebuilds his. Chandler is back in school now. He's using crutches and a wheelchair. And check out the incredible welcome back surprise he received. A standing ovation at an assembly where his classmates voted him Junior Class Homecoming Prince. It was an emotional day for everyone watching him up there on stage. Chandler will be fitted for a prosthetic leg. He'll go through some rehab with that, and then his new goal, a little spring skiing.
The reason we actually chose to start with that video is it encompasses so many aspects of injury, survival, healing, rehab. And I think it will bring us back many times tonight to many of the things that you actually saw in that video. I'm Doug Smith. I am an orthopedic surgeon. I work primarily over at Harborview. Thank you for the kind introduction. I really appreciate that. I have a number of jobs. I came to Harborview actually in 1989 for 1 year, and I'm still there. And many people don't realize Harborview has had programs devoted to the care for individuals with limb loss since the 60s. And one of the nurses that helped found many of those programs is with us tonight. Will join our panel, D Malko. Prosthetics research study exists in Seattle. It's where the Seattle foot was invented. I'm pleased that I get to work there now. We wrote software to help design, manufacture sockets, and we have a website, which is referenced here, that has a lot of education for surgeons about how to do amputations. It's not an operation that a lot of surgeons seen more as a difficult operation, one that's more of a failure, and the opposite needs to happen. It needs to be seen as positive and reconstruction. And our website for surgeons tries to do that, but it's something you all, as medical students now, can scan. The Amputee Coalition of America, another panel member, Laura Willingham, is with us. She's the regional representative for the Amputee Coalition of America, a national organization dedicated for information, education, and advocacy. And I'm very lucky that I've gotten to serve as their medical director and try to write some articles that try to give a point of view from the surgeon's point of view. And I have been very honored that I've got to help out a little bit and help the wonderful physicians helping our injured soldiers with the Army. The military medicine is just doing an amazing job. I'd like to start out just by saying, as you saw from this video, this whole aspect of helping someone who is facing limb loss or has had limb loss is a very big team approach. There is no one person on the team that can really do this. And if you'll notice, the top of the list is the nurses, and I would actually say I've learned the most over my career from nurses like D Malko, Mary Novotny, who was a nurse in Chicago that founded the Amputee Coalition of America, Patty Rosbach, who's the nurse that runs that organization now. You notice where they are. If you want a big organization, you want it to work, put a nurse in charge, not a surgeon. You know where surgeons are in the list. But med students, the surgeon's one part of the team, and the aspect of care that you saw in that video can't happen from one person. This is one aspect where everybody really needs to come together to make a good experience, a positive experience. So my task tonight was to actually, in about 20 minutes, maybe a little more, to cover all of amputation surgery. Not really possible, but I do want to focus on 3 things that I think the surgeon has a very key role in. That is decision making, performing the surgery, doing surgical technique, being reconstructive, being positive. And the last one, which many surgeons sometimes get and sometimes don't, is attitude. And I would say the little medical student tip at the bottom is, of those 3, I think the surgery is the easiest, which many people kind of go, huh? The decision making is actually very difficult sometimes. And maintaining and coaching and being positive in the attitude can be very tough. In the decision making, one of the things that we need to realize is that there are a lot of reasons that people end up facing limb loss, having amputations. Diabetic foot from infections or ulcerations or osteomyelitis. Vascular disease, when you lose the circulation to a limb. You get ischemia, loss of circulation. And you can get rest pain. Muscle hurts when it doesn't get oxygen. That's why heart attacks hurt. Likewise, legs can hurt. And gangrene. Tissue can die, tissue can mummify. You can actually have dead tissue attached to you. That's gangrene. And we have people that face these very difficult things all the time. Those top 2 are probably some of the nationwide, the highest reasons people lose limbs. High energy trauma, as you saw from the video, burn injuries, frostbite. We're getting more and more in this country severe necrotizing infections, necrotizing fasciitis. The media sometimes calls it flesh-eating bacteria. At Harborview, we used to see 1, maybe 2 a year, and then it went to 1 a month and 2 a month. We probably see 1 or 2 patients a week at our own center here in Harborview of necrotizing infections now. So Mother Nature is getting very aggressive. People lose limbs from cancer, congenital issues, severe deformities, and dysfunction and pain. They've had an injury, they had reconstruction, and it never worked out. And I sit down almost every week with people saying, would my life be better with an amputation if I gave up this foot that just doesn't work? And we have some pretty interesting discussions about the pluses and minuses of all that. So as a medical student, you need to learn about these different areas and some of the things and attributes of each. When I have those discussions, when someone actually is facing limb loss, I often say, you're in a spot no one ever ought to be in. And it's really true. Giving up a limb or having to decide to give up a limb. And one of my mentors, Sig Hansen, who is the former chair of orthopedics and is still very active in his foot and ankle practice, taught me back in 1989, there are certain discussions you never have standing up. First thing you do is find a chair and sit down. And I think that's one of the best lessons I ever learned from Sig Hansen, is that there are certain times, as medical students, as doctors, we need to sit down and catch our breath and realize this is not an easy conversation for them or for us as healthcare providers. And I think that was a lesson that I have tried to always maintain, is that there are certain times as a healthcare provider, you just need to sit down and really sit and talk. The reality of amputation, something my kids have said to me occasionally, something sucks. Amputation sucks. It is difficult. There are a lot of downsides. Even though you see on the media someone running with President Bush, a soldier who is rehabbed to do something amazing, a mountain climber with 2 amputations, a skier that has returned to skiing. You see the positive, but deep down, it's no fun to wake up missing an arm or a leg. And I think we can't overlook that that is a real thing. There's a real functional loss, there's a real change in body image, and there's often pain that goes with limb loss. There's things like phantom pain, this mysterious thing of if the part's gone, how can it still hurt? And yet the computer that runs your arm or leg is still there, and you can still feel your arm or leg even though it's missing, and it can even hurt even though it's missing. The good side, surgery, prosthetics, rehab, they are much better than 20 years ago. That is really good. One thing that in our amputee clinic at Harborview has been really fascinating to me is, and you need to be aware, there's a changing attitude that happened around the year 2000, 2001, 2002, where before that time we would sit and talk with people, and they were coming forward with the attitude that amputation is absolutely the worst thing in the world. I would rather do anything than lose my limb. any surgery, any reconstruction. What can we do? Because I never want to go there. That attitude was probably too far one way, because amputation in many cases made people's lives better. It allowed more function, allowed them to heal, get rid of an infection, start feeling better, start rehabbing. Interestingly, in the last few years, because of the media, and you see a computer leg on TV, we actually have people coming in often believing amputation is a little better than it is. And I've had people that have real problems, but not to the scope that traditionally lead to amputation. They're saying, I broke my ankle, it never healed quite right, it really is sore, and I want an amputation and an artificial foot. And sometimes we step back and have to catch our breath a little bit. And it's very interesting that there is this changing attitude. I think it's good because it highlights we're doing a good job with rehab and surgery, and we are making people better. But it's almost like the pendulum went from too far one way to too far the other. And I think as healthcare providers and medical students, we need to be aware that there is this attitude out there, and you have to understand where the patient's coming from. Is the patient coming from the point of view where they're scared to death of this and their view is worse than reality? Or is their point of view, which is a new one for me, that they're coming at it with an attitude that is actually better than we can give them, and we have to kind of bring them back to earth a little bit. And so this has been new in our clinic, and we've been talking about it more, but it really is very interesting. In decision making, when I sit with people, I think there's actually two situations that you have to be aware of and try and decide which one you're in. There are times when salvage, saving the limb, is not really possible. Sometimes it happens fast. This accident this summer that you saw in the video, there was no choice. His leg couldn't be saved. To save his life, all these things had to be done to stop the bleeding. There was nothing that could be done. Sometimes we see people with infections that are so bad, surgery needs to be done fairly rapidly, and there's really no choice. But other times, people are coming in, and a great example is a lot of the folks that get diabetic foot infections, where it's really starting to make them sick. It's really starting to impact the rest of their health. And it has kind of reached the point where, as a surgeon, I look at it and really realize it's kind of past the tipping point where the foot can't really be saved. But the family and the individual haven't quite gotten there. And one of my jobs is helping them sometimes realize there really isn't a choice. So there are situations where it's pretty clear amputation is the right thing, it needs to be done, but you have to work sometimes fast, sometimes slow, over a week, 2 weeks, or a month, to help get people to the point where they can make an incredibly tough decision. And we do a lot of that by outlining the plans for surgery and rehabilitation. An even tougher spot is when they really do have a choice, and they are trying to choose between more salvage surgery and living in the pain that goes with it, or amputation and rehab. And the option trying to sort out, would my life be better with, is a really tough one, and it takes a lot of education. It's where the support groups really help, the nursing education, the prosthetic education, having people go to a prosthetic shop and touch and feel a leg, and meet other people that have been through this. The interesting thing that took me a while to learn, and orthopedic surgeons, we can be a little slow, and sometimes it takes us a while to get things, but the point number 2 under the med student tips, first one, you have to realize, are you in a situation there is really a choice or not, to help counsel them. But the second one is, it took me a while to figure out that most people think about salvage, they automatically think salvage equals normal. And there's a big hurdle to say, if we keep going with saving your limb, there are going to be these real limitations. And trying to accurately help people understand that is interesting. But this concept, salvage equals normal, took me a while to figure out that that's what the patients were bringing forward to me. And it was my job to help kind of talk about that. When we get into the surgery itself, there's some things that really have to be done. You have to remove diseased and damaged tissue. We try very, very hard to preserve functional joints, like a knee joint, like an elbow joint. And we talk about the amputation levels. We'll have a diagram here in a minute. We need to reconstruct a limb. Someone will be using their arm in a way that was never invented. Someone will be walking on their leg in a way that God never invented that leg to be walked on. We have to craft the bone, the muscle, the padding to give them a new interface with the environment. So amputation is actually very reconstructive surgery. We are building a new way to touch the world. And we have to create as a team situations for very positive rehab, moving from rehabilitation and including prosthetics and therapy. And as medical students, students will need to learn all the details of the different levels, and here's just a skeleton that highlights 12 or 14 different amputation levels, and each one has unique anatomy and situations. So obviously we can't cover everything, but people lose limbs, all the way to the chest wall, sometimes called forequarter. They lose not just their arm, but their clavicle and their scapula, and they just have rib cage left. Sometimes people just lose a hand at the wrist. So there's all these different things that are really unique and different. And for our example tonight, we're going to talk about one of the most common amputations, which is an amputation below the knee. And it's interesting because you have limbs that have very little padding and the bone sticking out. You have other limbs that are padded in this fashion and in this fashion. And I'm going to highlight through some of this that one of our goals is not to end up with the bone sticking out and the bones prominent. We want things padded. We want them reconstructed so that they can work with a prosthesis. When I'm teaching our residents, and where we really get into surgery detail is in the residency, when the residents are helping us with the decisions in clinic and helping us in the operating room with the surgery and gradually doing a little bit more as time goes on between their first year and their fifth year of surgery. But we talk about the plan before surgery. How are we going to make skin incisions and flaps? What are we going to do with the nerves? What are we going to do with the blood vessels? How are we going to handle the muscles, the bones, and how are we going to get everything closed at the end? The handout has a lot of things that we're not going to cover, but I'm going to kind of clip through these different things just to give you an idea of some of the things we think about. The pre-op plan. Where do you cut the bone? What makes sense? Historically, people used to just put their finger on a bump called our tibial tubercle and put their hand down and cut the bone there. And for decades, people always cut the leg at that level, which is about, depending on your hand, 12 to 16 centimeters. And everybody's hand is different. That really didn't make a lot of sense. But that's how it was taught for decades. And interesting, even when I came out here in the 80s, many people still had that approach. Now we recognize the value of longer tibias, but not too long. When you get down to the lowest quarter and third of your leg, there's very little padding. How are you going to cover that with tissue that can tolerate someone's whole body weight? So what is a perfect solution? Well, it turns out somewhere in the mid to just shorter of mid-tibia makes sense, because you've got this great muscle in the back of your leg, the calf muscles, the soleus and the gastroc muscle that can be redesigned as padding. But we also have to think about space. Technology can't fit into just an inch. And many of the padding, the socket, the connector, the cool foot and ankle that you see in some high-tech magazine now, for low impact things, you need about 3 or 4 inches between the end of the limb and the ground. And for some of the really interesting stuff that many of the soldiers are using, you need about 6 to 9 inches. So you have to leave enough space to allow technology to work. So a practical length often is about 1/3 to half the length of the tibia. Much shorter than many of our patients realize when they come in and you show them where you're going to do the surgery. They go, oh my, I didn't think it would be that high up. And then you have to explain why and what the goals are with the padding and why we're going to try and reconstruct this limb. So we design all these kind of crazy incisions, and there's many different ones that have been designed. Long posterior flaps, sagittal flaps, skew flaps. They have different names and different designs. We try to avoid thin skin. The anterior skin is very thin, and we try to avoid using that. And sometimes then we'll even do these kind of drawings, and we will be highlighting where does the skin actually fold from. You have to know where it folds from to know how long to make it and how long to design it. And so we often have these discussions in the operating room that the skin really folds from the back and wraps around. And you need much more skin. It's interesting. It took me a while, and I think it was, again, another nurse that pointed out to me, the patients really don't understand. There's somehow this view that everything's just kind of cut off at one level, like might happen in an old French guillotine. And then how does it magically get covered and closed? And actually doing little drawings about we're going to move this to here to provide the padding helps the patients understand and get it. And those kind of discussions get people involved and, one, make it a little more real, but also make it a little less scary. So I do a lot of drawings with the patients, and we write on their leg. I actually take a pen out and mark pictures about where we might do things. And that really helps, I think, people understand. The nerves. There's 5 nerves in our calf. Those nerves are like hot wires that have a lot of signals going downstream and upstream. And we need to think about those to make sure we know where they're at and try and manage all the nerves and shorten them so they're not going to be trapped in areas of scar and pressure and blood vessels. And it's interesting, many people unfortunately have had surgery that's probably not done with the best of techniques. And I look at their operative note or talk to a surgeon, he said, yeah, and I found the nerve. Like, the nerve? Yeah, that tibial nerve. I found that tibial nerve, and we took care of it. And I said, well, what about the other 4? And it's like, oh. Unfortunately, that happens. Sometimes amputation's not looked at as the most positive of surgery. But there's 5 nerves that ought to be addressed and really managed. And here's just a little schematic. You know, the saphenous kind of running down the medial of your calf with a big vein. And our perineal has a superficial and a deep portion. And the tibial nerve is the big nerve that's in the back of our calf that gives the feeling to the bottom of the foot. And a small nerve called the sural nerve is very small, but often creates a very tender spot at the end of the amputation if you don't think about that nerve and really stretch that nerve down so that it retracts. And the end of the nerve is not in the area where it's going to be a problem. When the nerves are cut, they try to regrow, and they form a little mushroom of nerve tissue and scar tissue that can be really sensitive. So if you leave that in the scar, it will get entrapped and create a painful neuroma. Or if you tie it right near a blood vessel, it can sense the cadence of the vessel, and people might feel a throbbing inside the leg. Blood vessel groups, there's 3 major ones in our calf, and we really need to address them to make sure, one, bleeding is bad. So you really need to be securely ligate the vessels so you don't have any bleeding afterwards. And we try very hard to avoid getting the nerves and the vessels close together, because we don't want the vessels sensing the cadence of we don't want the nerves sensing the cadence of the vessels, causing a throbbing feeling. We think about muscles in 4 compartments. And interestingly, 3 of them, we really shorten the muscle near where the bone is. But the major one, the back, the calf muscle, the gastrocnemius and the soleus, are brought up with their muscular investing fascia. The old technique was to cut through the muscles and leave them beveled. And now we leave them thicker and better covered to be better padding. And here's the bones, some example of the kind of saws that we use in the operating room. It's a saw that vibrates, and it cuts through bone, and we're cutting a tibia right in here, and here's where we're dividing a tibia. And we put a bevel. The tibia is like a triangle, and if you leave the point, it's going to hurt people. It's going to be hard to wear the prosthesis, so you have to shape the bone. And in the bottom, when we're shaping the smaller of the 2 bones, the fibula, and you need to cut the one a little shorter than the other. There's an interesting kind of concept that's come and gone since World War II called bone bridging. There's a physician named Erdl in Hungary who decided these 2 bones are kind of joined near your knee, and they're usually joined near your ankle. And in an amputation, they're no longer joined. And there's big debates on whether rebuilding a connection to those bones can really help or not. And there's a lot of theory. I get patients that come in a lot with internet articles saying, I need this. You need to do this bone bridging thing. And sometimes they're right. It would help. And sometimes there's downside to everything. Maybe it won't heal. Maybe it will get infected. Sometimes if you try to do too much, you can end up worse off. So we counsel people on what the theory is, and this is a great example, and what the reality is. And I usually tell them I'm very supportive of these reconstructive concepts. I think of this as a reconstructive operation. But the reality of some of these things doesn't always equal the internet hype. And I found our medical practices these days, we're often discussing what's on the internet. Because the patients they will bring you as medical students, they will bring you these articles and say, what about this? I need this. And so you have to understand what's out there and what the patients are coming forward. Here's a case where it was very appropriate, very severe trauma, and the 2 bones were splayed apart. And if we had left them like this, it would have been very difficult in the prosthesis. So we actually did build a connection between the 2 bones with a block of bone and a screw to reset them more anatomically. And so sometimes this really does make sense. And there's other times where if someone has an infection, you really worry that this will just cause more infection. So we have to have those kind of conversations. And then we close things up. A myodesis, sewing muscle to bone is what myodesis is. And you can do it in a couple ways. You can sew it to the periosteum or the covering of the bone to get a secure fixation, or you can actually drill holes in the bone and place suture through the bone and sew the muscle right to bone. And then the fascia, the envelopes that cover our muscle, we need to close that to keep the muscle contained and help it to heal. And then we have to think about the skin. Many of our patients heal very slowly. Folks with diabetes or vascular disease often don't heal as fast as when they were 17 years old. So often we have to consider that these stitches might be in 3 weeks, 4 weeks, 5 weeks, 6 weeks. How are we going to maintain a situation that's okay through a longer healing time? Why is padding so important? Well, Dr. Burgess, who is an orthopedic surgeon from Seattle, he passed away a few years ago from a stroke, but he invented the Seattle foot. He taught reconstructive amputation surgery for years. I came out here, he was one of the 2 people I really wanted to work with when I came out here, and I was privileged to work with him. And he popularized a Burgess Style amputation that we use a lot. But sometimes the padding can fade. And here's an example where the padding used to actually be up over the bone, and over time it's stretched out. Unfortunately, the human body sometimes stretches and sags. And I'm 48 years old and starting to stretch and sag, and it happens even more sometimes as we get into our 60s. So if the padding shifts, you know, even though we positioned it, this can be a problem because it's a pressure point in the prosthesis. There's some solutions the prosthetist will talk about to make it better, but surgery can sometimes help, and we've tried to do things, especially for our younger patients, for extended padding. And it looks really bulbous and puffy because your muscles are actually big, but over time they thin down. And a situation like this ends up here where someone actually has more padding up and over the bone. And so see, these are some of the positive things we've been looking at with surgery to help people, not just with their healing, but also with their rehabilitation and with their interface with their prosthesis, their artificial leg. Here's another gentleman. He was 70. Horrible osteomyelitis for years. Flare-ups and flare-ups and flare-ups. And the interesting thing is this was very severe infection and worries of turning into squamous cell cancer, which wounds that are 8, 10, 15 years old can do. This part was all skin graft, just stuck to his leg, would not have held up to the forces of an artificial limb in walking. He had good circulation. Fortunately, he was 70 and had never smoked his whole life, and he was very healthy. And we actually used a huge flap, as you can see here, and really re-inset this to make a padded situation. And he healed and got back onto life. And actually, once his infection was gone, he said, it was like getting rid of the flu. I'd felt like I had the flu for 20 years. Everything was always achy. I'd respite these fevers. And he said, now that this bone infection is gone, I no longer feel like I have the flu. He also said food tastes better. We had to caution him because food tastes better, you often gain weight. And he said, you got to be careful. Now that food tastes better, you got to really watch out. The last thing I want to talk about the surgeon's role is attitude. And I believe that positive attitude is absolutely the most important of the 3. Often it is the hardest, especially if you're facing something like an amputation surgery or a discussion. The execution of the surgery, excellent technique should be expected. But by attitude, I mean the coaching and positive motivation. And I think Dr. Chernicki will be coming up in the rehabilitation side of things, amplifies that we really, as physicians, we need to coach our patients to positive outcomes. Our job doesn't end when we put the last stitch in. It's our job, like the coach of a team, to get the players to perform a little better. And if someone is really faltering in their postoperative healing, I've seen surgeons blame the patient for that. And I sometimes step back and say, well, is it the patient's fault or is it the coach's fault? Because as surgeons, we need to be coaches. And I think this is a bigger part of the job than I was ever taught. And the more I'm in this field, the more I realize that a big part of a surgeon's job is this, coaching and positive motivation. I would like to, as in many medical student talks, give you a couple of resources. There's a couple of great websites that have a lot more, both the first one on surgical technique. It's one that I'm actually proud of because we're trying to teach more people the positive aspects of surgery through a website. And if you are not afraid of the gory details, which you're all here, so you're not, you can actually watch amputation surgeries on that website. The second one, In Motion Magazine, is the official magazine of the Amputee Coalition of America, and there's a lot of articles directed to people facing limb loss who have had limb loss that gives tips and tricks and what it's like to live without a leg. And you'll get some of that tonight, but you can get a lot more at the website. So I'd like to thank you for my part on listening to my part on surgery.
So that said, I would like to have our panel come up of amazing people, and you can ask them a few questions about what it's like to live with a prosthesis. So could we now have our panel members please come up?
To start off with, I think it would be great to have each of you introduce yourselves to the audience and just sort of let them know a little bit about yourselves, just in general terms, and then we'll kind of move forward from there. Laura, do you want to go ahead and start?
Good evening. My name's Laura Willingham. I'm 30 years old. I'm an above knee or transfemoral amputee. I was in an auto accident when I was 21 years old, and my right leg was severed. And I've chosen to work in the field of limb loss and limb difference through the ACA, and I've had the honor and privilege of working for prosthetics research study under Dr. Smith. And now I serve as the regional representative for the Amputee Coalition of America, working to link other amputees to one another in the Pacific Northwest.
Thank you.
And Joe McGuffy, as Danny once said, when I help him during the summertime with his patients, or with his kids down there, and Mac's an ideal patient. He has everything wrong with him. But anyway, 4 years ago, diabetes. I got a bad ulcer on the left foot. When I checked into emergency, I had about 36 hours left. I waited too long. Male pride got in the way. Also suffering from neuropathy on the right leg. And to summarize that, no feeling here, no feeling here. It makes walking a real sport. But I try not to let it get me down too much. I carry a 15 golf handicap still and enjoy life just as much as I can.
Thank you. Dee?
My name is D Malko. I'm a retired nurse from Harborview. I was in a boating accident when I was 19 years old, which was about 43 years ago, so I won't tell you how old I am. When I worked at Harborview, I was a part of an effort to set up a special program to smooth out the impact of amputations. And the support group is still going there, and the program is very viable. So it was a privilege to do that. I'm married and have 2 grown children. I have 6 grandchildren. And I'm now focused on working with amputees in West Africa.
Thanks, Dee.
My name is Chandler Balkman. I was also in a boating accident. I was the one you saw in the video. And I am an amputee at the hip. I'm a hip disarticulate, and I am a junior at Issaquah High School and have plans to become a doctor if all goes well.
Hey, Matt?
My name is Matt Waters. I was wounded in Iraq 4 years ago. It'll be June 11, 2003 is when I lost my leg to a rocket propelled grenade, which is a shoulder-fired rocket used to take out tanks. He decided to try to shoot me with it, and I returned the favor. It's been, thanks. It's been a hard road to hoe, but you know, a couple years ago I went on with the Tacoma Police Department. They hired me, and I've been there for 3 years now, and love every minute of it. You know, I dropped one gun, I picked up another, so I'm out there helping protect you guys. There's a lot of us, so that's where I sit right now.
Thanks, Matt. So you can see that we try to provide a sort of a balance of people that have really come from many, many different backgrounds, experiences, to kind of enable you to ask the questions that you'd like to ask. So at this point, let's see if we have some questions. Both Danny and I have some questions because I'm interested to learn more, but let's go ahead and have you participate.
There's microphones, if you could please go to those that are in the aisles.
Everybody shy this evening? Here we go. We'll always take somebody to start it off. Thank you.
I had a question regarding the group decision-making process, and with respect to if a patient is a minor, how much decision he or she has, as well as their parent?
That's a good question. Probably you weren't in too much shape to kind of help out with the decision making, I'd imagine, at that time. Doug, you probably knew more about the acute situation at that point. And
yeah, I think that like a lot of things in trauma, the informed consent process is very different than when something's elective. I think our first obligation of physicians is to keep people alive and to save as much function as we can. But we obviously work a lot with families and typically those decisions go to parents for minors. But if it's a slower decision process, I am very conscientious of making sure that the young person is very involved. Obviously, I would never do something to someone that's against their will, so it's building consensus and information and getting everybody on board. I think one of the hardest we face is a lot of cancers in the limbs. An osteosarcoma happen to very young people, often 10, 12, 13 years old. And so we're facing sometimes discussions about limb loss with young teenagers and their parents. So that's the one that comes to mind the most. And Dee actually has been involved in that process of young people reaching those decisions. I don't know if you have comments on building consensus with families for a very difficult decision, Dee?
I agree with you. I think it's a team approach. I will say it's probably one of the hardest decisions that a parent ever is called on to make, because they're always, concerned about having to make that decision for their child. If their child is not responsive, if they're, unconscious at that point, or if their child is quite young. So a lot of times they will stall as long as they can, because they do want the child to be alert to what's going on. But any of you that are parents, it's agonizing to have to step in and feel like you're making an irreversible decision like that. So you do try and incorporate the child as much as possible.
Thanks. I'd like to ask each of you to maybe sequentially sort of, I'm always interested in what you view as the greatest challenge and adaptation to becoming an amputee. And maybe if you could just give each of your personal perspectives on that.
Well, my leg was amputated when I was 21, so I was at that one of the many critical life stages that we go through of defining who we are to our communities and who we are to one another, to ourselves personally. And the biggest challenge that I felt that I had, and still to this day have, is not the loss of a limb, but the loss of the spontaneity that a whole physical body provides you. So where I remember very clearly in college wanting to go out with my girlfriends after studies and go to a movie, go to a party, go have pizza or what have you. I had to make several decisions aside from that, saying, can I physically endure that? Will tomorrow be too much of a hassle for me to endure that? So the loss of spontaneity is probably the biggest challenge for me.
I think the hardest part was the first 2 years on it. It's just you have to readjust yourself. The human body is an amazing thing, but you've got to learn how to walk again. You're a baby, and every step you take, you have the potential to fall down and hurt yourself very bad. The rehab programs that they have do a marvelous job. I stumbled down 27 stairs and do the training that I got out of rehab. I didn't break anything, and it was just amazing on it. And along with this, with diabetes, if you have it at one time or the other, you're going to get depressed. And they have some very good programs that help in this. I know when it's coming on, I just kind of withdraw for a day and stay away from everybody, because I can't even stand myself on those days. But as I say, life is good.
Thank you. Dee?
Boy, I really hear what they're saying. When she talks about the spontaneity, I had a patient say once, I can do what I did before, but I have to think about it first. And there is something very real about that. I believe that as a nurse with a focus on psychosocial issues, that just kind of getting that sense of who you are, your identity, and getting through some time of grief about losing something so precious as a part of your body. I think sometimes in our country there's a fault with saying, hey, you'll be okay, just buck up, hang in there, be strong. And it's kind of like saying you don't have the privilege of sitting down and feeling rotten about something very rotten that's happened to you. And sometimes that makes it harder down the road when all the multiple things that we encounter happen, the things that are slowed down, the things that are a major nuisance in your life. The relationships that you're questioning, you're wondering about. I feel like sometimes that's a big barrier, and I was grateful that I allowed myself some grief time, but I wasn't good at doing it in front of people. So I'd do that privately, and then I could keep a smile going and keep moving forward. But I think that's one thing to keep in mind, that people need the privilege of having some downtime.
Hardest thing for me, my accident's pretty unique, or pretty unusual. And for me, I have a lot of pelvic discomfort, so sitting and walking is hard because I'm bearing weight through my pelvis. But I walk slower, and I don't always keep up with my friends, but my peers are great about it. But the hardest thing is constant discomfort, and knowing that I probably won't run for a long, long time, but I may. But just making the adjustment was okay though, because I stayed positive. I just decided to be positive because there's no use in trying and not trying to be.
Thanks. Matt, how about you?
Biggest challenges are extension cords and Christmas tree lights, to be honest. When you're walking through the garage, they get me all the time. There's been a few times I've fallen flat on my face, and you swear at yourself, and like everyone else is saying, you want to buck up and tell yourself you're all right. And I portrayed that to several of my buddies when I was still in the hospital. In fact, on the same mission I got shot, one of my buddies had been shot through the hand, and he came up to see me, and his face was white, and I kept telling him, hey, I'm fine. And you put on this show for everyone else, but inside, your mental state is still, it was way too early for me to be telling people I was all right. I said, hey, what you see is what you get. I am jacked up. Get used to it. But as far as me, I was blown up. The stuff that I have to deal with, a lot of stuff is after the fact, and stuff that I have to deal with the rest of my life. Just like he was saying, each one is unique. Each one has to deal with something different. In my case, it's shrapnel or foreign bodies inside my residual limb. Dr. Smith pulled a stone out of me last year, but about this time, and a couple pieces of shrapnel. So, each one's different, and that's, for a lot of the traumatic amputees coming from Afghanistan, Iraq, you're dealing with, not only these limbs being ripped from your body, but things being ejected up in there, or not ejected, but thrown up in there. So.
Do you have any questions? Yes, thank you.
I heard that after a certain time, people with prosthetic legs, they could feel it. So I was wondering first if it was true, and also if they can feel it, what kind of sensation they get from it.
Well, for me, I can predict more now. I can sort of predict where my foot's going to end up in space, and to an extent, assume certain things that I couldn't before. But I certainly can't feel my foot in space. And one way you can, I feel like amputees can hide pretty well in communities with the aesthetics, with the physical therapy that's available today. I think people can really assimilate with their communities really nicely. But the one trick that I've always seen, I don't know if you guys do, I always look, if somebody's constantly looking at the ground with every foot placement, I'm assuming they're probably an amputee, because we're constantly evaluating the ground beneath us and looking for the safe space to put our foot for those of us that are missing our lower limbs.
I think the hardest thing is overcoming your pride. You've got to accept what's happened to you, and it's very difficult to do, especially that first year. You get into the self-pity stage, and fortunately I was blessed with 5 friends very close around me that pulled me through it. I might not have made it without them. But with the neuropathy on this right leg, it makes things very interesting. Ideally, everything is ground level. There's no stairs, no steps, no nothing. Stairs give me more fits than anything else, that and the shower.
Well, I agree that you do need to keep your eyes on that floor ahead of you. Just a little twig, a little pebble, a little unevenness in the sidewalk. If you're on a predictable floor, you're okay. But you get off of it, and you better keep your eyes open. And kind of like the Christmas tree wires and whatever. I mean, something, I can do really good in a lit room, especially with a predictable floor. But you put me out in the backyard at night without a flashlight, and I'm working at it to stay up because I can't see those little divots that I better, counteract my body with. So I can do pretty well in the daylight.
For me, like feeling, when as for like phantom pain, I think phantom pain is much different for everyone. I'm a pretty new amputee, so I'm still experiencing some, and it may persist and it may go away. But while I'm walking, sometimes I'll feel my phantom leg actually dragging behind me, like I'm tripping on something. But really, it's not, nothing's there. And phantom sensation is interesting. You get phantom itches, tickles. I mean, everything. It's really interesting. But when I take my leg off every day, I can kind of feel a little heightened phantom sensation.
As far as hitting or missing the ground, I had my prosthetist build me that it actually helps me out quite a bit. He integrated a knee brace into my socket, which comes up partway up my leg. Given my job, when I go chasing suspects through the dark over fences, and well, it has to be done. So a little bit that's personal too. You want to get those guys. Because you want to think, hey, I'm the one-legged guy, and you want to say it to him too. You're like, hey, you just got jacked up. But he built me a knee brace that when I do go running and I do hit those divots, that I'm not on my face, that I can keep going. I'm also into extreme sports. I do motocross. In fact, I went riding yesterday, and I wear my knee brace. And if I didn't, there's no way I could do these other things, just because of the aspect of being an amputee. In fact, it happened at the academy. I hyperextended my knee and I was out for 2 weeks. And I can't let that happen on the streets. If I'm in a fight for my life, that's the last thing I need to be worrying about is more pain. The phantom sensations, I went through it. You get those itches and you're just like, what am I gonna do about this? I mean, it'll drive you nuts if you think about it. Sometimes people see me and I'll be stomping my leg on the sidewalk, and that's just to maybe trick that nerve into thinking that I'm itching it just to knock it loose. People might think I'm freaking out, but well, you almost do when you got those itches or those pains, but you'll do anything to get them to go away.
What they're describing is something called phantom sensation. You've probably heard about phantom pain, where you have pain in the extremity that's missing. Phantom sensation is where you can perceive that the limb is still there, even though it's missing, and you can actually feel like you can move the leg, you control the position of the leg, or in fact that sometimes you can't control the position of the leg, and in your sort of cognitive memory that the limb is actually positioned in some unusual position and it always stays in that position. So the kinds of sensory experiences amputees feel in the part that's missing are, offer a huge and wide spectrum, sometimes quite disconcerting. So those are some of the things that are being described here.
So I wanted to acknowledge now that it's 10 after 9, and if this was my class, you all would have packed up and left already. But these people are clearly more interesting than that. Thank you for staying. I think the people here, our panel, will stay around for a little while and would probably be happy to answer your question on an individual basis. And we can continue the question and answer if you would like, but also if you have to go, we understand.
Thank you.